Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another important lecture. Today we are studying the salient important features of a full thickness macular hole. So what is meant by full thickness macular hole? The macular hole, as the name suggests, it is a full thickness defect or depletion in the area of retina, specifically in the macula. That's why it's called a macular hole, right? Now, important point to notice here is the full thickness defect occurring in the area of macula. Now, it is first described by the scientist named Knapp and in a patient with a history of ocular trauma. So, all those earlier descriptions of macular holes were actually focused on young traumatized eyes. However, now it's a well known fact that the traumatic macular holes are not very common, but what is more common is the idiopathic age related macular holes, which occur in the older population. Coming to the epidemiology of the macular holes, they are a relatively uncommon problem of the retina with an incidence of about 0.2 per 1000 persons and 3.3 per 1000 persons according to the Blue Mountain study and Baltimore Eye study. However, the incidence is about 8 people per 1 lakh persons developing macular hole every year. Holes are bilateral in about 5 to 20% of the cases, but full thickness macular hole will rarely present simultaneously. What I mean to say is that one eye develops macular hole much ahead of time compared to the other eye. Now, full thickness macular hole occur in about 6 to 7 decade of life. However, the traumatic macular holes can develop earlier. Moreover, the myopic patients also they have a tendency to develop macular holes and they develop it much younger in life. The female to male incidence is about 2:1. Okay, so females are more prone to developing the macular hole compared to males. Before we understand the macular hole further, it is important to understand the vitreous attachments. Now, vitreous has a strong connection with the retina at certain places. So, these are the vitreous base, which is an area of about 3 to 4 millimeters surrounding the ora serrata. Then it is strongly adhered to the optic disc, it is adhered to the macula, and then also to the blood vessels. Now, normally with the age-related changes, the vitreous is eventually going to separate from the retina and from all its attachments, okay? And this will usually be a physiological condition which should not cause any problem, any kind of tears in the retina. However, because it is adhered so strongly at certain places like the vitreous base and in the macula, sometimes when the vitreous separates, it takes away a part of retina along with it because of the pull or because of the traction. Now, such conditions will cause a lot of anomalies or pathological conditions in the retina. So, such sometimes, for example, what I mean to say is the vitreous can separate from this vitreous base and sometimes can pull a part of retina along with it and cause a development of a retinal tear or a horseshoe shaped tear in the periphery of the retina. Similarly, vitreous can also tear at the area of the macula, which we are concerned in the macular hole, and can lead to a development of the macular hole. So, macular hole also comes under a type of disorder which falls under the vitreoretinal interface disorder because it is occurring at the vitreous and the macular interface. Now, so what are the most common causes of macular hole? The most common one is the age-related or idiopathic macular hole. Then we have the traumatic macular hole and high myopic associated macular holes. Now, there are a lot of uncommon causes, and all the uncommon causes basically are related to some sort of cystic change in the macula. So these are the cystoid macular edema, proliferative diabetic retinopathy, severe hypertensive retinopathy, choroidal neovascularization, and even solar retinopathy. These conditions can also be some of the uncommon causes of development of macular hole. What is the difference between primary and secondary macular hole? So primary macular hole is nothing but it is an idiopathic macular hole. Okay, so it is caused by the abnormal vitreous separation causing attraction at the fovea, right? But secondary macular hole is caused by a pathology that does not cause traction on the retina. So when the component of traction, which happens with age-related changes, occurs, that's called an idiopathic macular hole or a primary macular hole. There is no disease as such in the patient. However, when there's some particular pathology or some particular disease in the retina, like blunt trauma causing macular hole or high myopia predisposed patients developing macular hole, presence of macular telangiectasia type 2, or various kinds of macular edema. So such macular holes are called the secondary macular holes because they are developing secondary to some of the pathologies in the retina. Now, based on the diameter of the macular holes, again we have three types of macular holes. These are the small, medium, and large macular holes. So, small macular holes are those in which the diameter is less than 250 microns. Medium are in which the diameter is 250 microns to 400 microns, and larger one is greater than 400 microns. Now, at this point, let me make it very clear to you that this classification of small, medium, and large is given by the IVTS, that is intravitreal tractional study, okay, which has classified this macular holes into small, medium, and large. So these values have been given by the IVTS. These values are totally different from what was given by the GAS. Okay, the main scientist who is involved in the study of the macular holes, which we shall be discussing now after in a while. Now, how do you actually measure the size of the macular hole? The size of the macular hole is based on the minimum hole width at the narrowest point in the mid-retina. So, we know that the retina can be arbitrarily divided to inner, mid, and the outer retina. So, at the level of the mid-retina, the thinnest diameter of or the narrowest point in the mid-retina of the hole will be taken as the width of the macular hole. So as I told you, it is the IVTS classification which told you about the small, medium and large. Apart from that, the International Vitreomacular Traction Study classification also classified macular hole based upon the presence or absence of the VMT. What is VMT? VMT is vitreomacular traction. Okay, so I have explained to you about the vitreomacular interface disorders on my video on which I posted before this video. So vitreomacular adhesion is nothing but in which there is an adhesion between the vitreous and the macula. However, this is a normal physiological state. There is no distortion of the foveal contour in this condition. However, vitreomacular traction is a pathological condition in which, apart from having the vitreomacular adhesion, there is also a distortion of the foveal contour due to that traction element of the vitreous on the macula. And eventually, this vitreomacular traction will go on to develop a full thickness macular hole. Now let us discuss about the pathogenesis of the macular hole. So how does the macular hole develops? So there are numerous theories for development of macular hole, and these are the traumatic theory because this was first studied, and then we have the cystoid theory, the vascular theory, the vitreous theory, which is the theory of anterior-posterior traction on the macula, and the mixed theories, which are the most accepted ones, in which says that there is a component of anterior posterior traction, plus there's tangential traction as well, plus there is hydration associated with macular hole formation. So let us see what are all these theories one by one. So the first one that we have is the trauma causing macular hole. So macular hole is usually associated with the blunt trauma. So what happens is whenever there's a blunt trauma, something hitting directly straight on the eye, the blunt force will be transmitted through this sudden globe compression, and this force will be transmitted as fluid waves in the vitreous, and that will go and hit on the macula, leading to a countercoup injury on the macula and causing a foveal rupture. So that is a traumatic theory, but and how do you actually diagnose that this is because of trauma is that obviously there will be history of trauma, and apart from that various other fundus lesions which are specific to trauma like the choroidal rupture or Bruch's membrane disruption, commotio retinae, which is also called the Berlin's edema, and various peripheral breaks. All these will indicate that there has been trauma, and trauma is the reason for the macular hole. Now in this picture you can see this patient had a history of trauma, and here you can see a choroidal rupture, and you can see this is a macular hole. So normal idiopathic macular hole will not be so large in size and will not be so irregular as shown in this picture. The second theory for development of macular hole is the cystoid theory. Cystoid theory says that any condition which causes cystic degeneration of the macula can lead to development of a macular hole. So what are these conditions? These conditions can be severe hypertension, diabetes, vein occlusions, or sometimes even trauma causing cystoid macular edema. Ultimately, all these cysts are going to fuse together, leading to formation of a bigger cyst, and then the roof of the cyst will get avulsed, leading to a macular hole formation. So what I mean to say is initially so many conditions lead to formation of cystoid macular edema as shown here, and then these cysts are going to get fused together with each other and finally form a large cyst, and then finally because of some reason there will be deroofing or thinning of the roof, and ultimately there will be formation of the macular hole. So what did I tell you? Macular hole is full thickness hole. So as you can see, the entire retina is actually, there's an entire depletion of full thickness defect, or the full thickness defect is actually present in the retina. Third is the vascular theory. So what is vascular theory? Vascular theory was given by Coates and Kunt. They also believe that with age, there are some changes which occur in the retinal vasculature, and that is called the ocular angiospasm. So with age, the vessels will undergo angiospasm, and subsequently they will lead to formation of cystoid changes in the macula, and ultimately we know how cystoid changes will lead to a macular hole formation. Apart from that, again, we have a vitreous theory, which is also called the anterior-posterior vitreous traction bands theory. According to this theory, there are certain anterior-posterior vitreous traction bands, which mean that what I mean to say here is that if this is your eye and this is the cornea is present anteriorly and the retina is present posteriorly. In between, you have the lens. So anterior-posterior traction means that there are bands which are coming from the vitreous and getting attached almost at 90-degree or say some acute angle to the vitreous, and then they are pulling it forward towards the cornea, towards anteriorly. So that is called the anterior posterior vitreous traction. So because of this anterior posterior vitreous traction, there will be traction on the macula, and ultimately you will have again those cystoid changes, and finally we will have the development of the macular hole. So you can see that the cystoid changes, and ultimately this traction band has actually pulled a part of that cystic roof, and the roof, this upper part of the cyst has been deroofed, and you can see this opening leading to formation of a macular hole. Now, the current theory says that the tangential traction also has a role along with the anterior posterior traction, and this is a scientist who was majorly involved in the study of the macular holes, and he is Donald Gass. And he said that in his study, he said that the tangential traction along with anterior posterior vitreous traction, they lead to development of the macular hole. In his description of the various stages of the macular holes, okay, which is also called the Gass classification, he hypothesized that it is the shrinking of the prefoveal vitreous cortex that leads to the anterior traction on the retina. So what does it mean? What I mean to say over here is that, so if this is your macular area, this is a foveal depression, and we know that the vitreous is here and the vitreous is attached to the retina all around. Gradually, as with age, it starts separating, and it separates perifoveally when it reaches the macular area. So what did Gass say was that this vitreous which is present in front of the macula is called prefoveolar vitreous. This vitreous will start undergoing some amount of condensation and contraction, and as it undergoes contraction and condensation, it not only pulls the retina forward, but it also causes some amount of horizontal traction, which is called a tangential traction, right? So because of that horizontal tangential traction and anterior posterior traction, finally there will be development of the macular hole, right? So posterior hyaloid tangential traction on the fovea and umbo will cause stretching. So as you know, this is the macula. Then we have various parts of the macula. We have the fovea, inside that we have the foveola, and then we have the topmost part, which is called the umbo, which is corresponding to the foveal pit, right? So the umbo is the thinnest part. So whenever the tangential traction or anterior posterior traction occurs, it is the umbo which will give away. So as you can see here, this is what Gass meant, that the prefoveolar cortex will undergo this contraction. So it will have an anterior posterior traction element, because of which the retina is going to be pulled forward, as you can see here, and there's some cystic space which has developed. Okay, and apart from that, along with the anterior posterior traction, a component of tangential traction will also occur, and after some time what will happen, the roof is going to give away and the vitreous is going to seep. The vitreous fluid, we know that the vitreous will undergo liquefaction with age, so all that liquefied vitreous is going to find this opening and enter this mid and outer retinal area, leading to expansion of the holes. So along with the anterior posterior traction there is tangential traction, and you can see here there is this hydration of the retina which is occurring, which is leading to the expansion of the macular hole. So this is what I explained here, that the middle and the inner retina will finally absorb the vitreous fluid at the exposed edge of the hole and start expanding. Then there will be a lateral extension of the fluid into the outer plexiform layer. So it is this outer plexiform layer which is going to start accumulating the fluid and then start extending laterally. So this is what is the hydration theory. Now, Gas also suggested something about the Muller cell cone. And what is this Muller cell cone? The Muller cell cone has been drawn here with this red color boundaries. Okay, so the apex, it's actually an inverted cone. So you can see this is the truncated or a sort of a flattened apex of this Muller cell cone. This apex is present at the external limiting membrane, whereas the base is formed by the umbo, which is actually the foveal pit, and this depressed walls of the fovea. You know, we know the fovea is not straight like this. The fovea has a depression like this, which is called a foveal depression, right? So these tapered walls of the fovea is called the clevius, and the pit or the exact center is called the umbo. So this umbo and the clevius, they will actually form the base of this cone, and the end, the apex is formed by the external limiting membrane. And all the cones which are present, the cone bodies which are present in the outer nuclear layer, are going to be situated somewhere in this cone in between the Muller cells. So Muller cells are going to form the structural framework for those cones which are present in the central foveal area. So there are a lot of functions of this Muller cells present in the Muller cells cone. First is that a lot of xanthophyll is concentrated in that Muller cell cone area, right? So with time what happens is, and because of the traction element, these xanthophyll elements are going to migrate centrifugally. That means away from the umbo like this, and that will actually give you the appearance of yellow spot and yellow ring that you see in the gas classification, which you are going to see in a while. Right, so just remember that the Muller cell cones have a lots and lots of concentrated superficial xanthophyll. Apart from that, that conical area which has lots of Muller cells will also give the structural support to the radiating cone inner segments. So the cone's inner segments are going to be located in this manner, and in between them we have the Muller cells. So Muller cells are actually providing support to the cone segments. So any damage to that area will also damage that cone segment. Apart from that, these Muller cells can also invade the prefoveolar vitreous cortex. We know this is the Muller cell cone, right? So all the Muller cells from here, they can also invade this vitreous which is present here and initiate a lot of cellular remodeling and contraction, leading to the tangential traction, the centrifugal, that is outward migration of the photoreceptor and the xanthophyll. So at this point, it should be very clear to you that the macular hole formation is not just because of the traction, but also because of the centrifugal migration which is occurring because of the consequent or the subsequent hydration. You have seen that the fluid is going inside the outer plexiform layer. So the outer plexiform layer is getting laterally displaced. Along with that, the photoreceptors are getting displaced, and even the xanthophyll which is situated in this Muller cell cone is getting displaced centrifugally or laterally. Now, if you would have seen any illustrations from gas, you would actually have come across this diagram. So this can be quite confusing. However, let us have a look at it one by one. So according to Gas gave his classification just based on biomicroscopy because OCT was not available at that time. So according to him, the normal fovea looked like this. And this is now, after that we have stage 1. Stage 1 is called the impending hole. Impending hole means that the hole has not yet developed, but it is prone to develop a macular hole. The patient is prone to develop macular hole. In that, again, we have stage 1A and stage 1B. In stage 1A, Gas said that in the fundus we will see a yellow spot, whereas in stage 1B we are going to see a yellow ring formation. Now, why do you think he said there's a yellow spot or yellow ring? Now, according to Gas, he said that stage 1A, the yellow spot occurs because of a serous detachment of the retina at the fovea. Detachment of retina is nothing but when the neurosensory retina gets detached from the retinal pigment epithelium, right? Now, since this detachment is occurring at the level of the fovea, this is called a serous retinal detachment of the fovea. According to Gas, this is the reason for development of the yellow spot at the fovea in stage 1A. However, that time OCT was not available. Now, when the OCT was done, you can see that in the OCT you can see some cystic changes in the inner retinal layers in the fovea. Now, what about stage 1B? Now, according to Gas, stage 1B consists of the yellow ring. Now, why do this yellow spot change into yellow ring? Because he said that maybe that serous retinal detachment which occurs at the fovea now will also be associated with lateral displacement of the xanthophyll which is present in that inverted foveal Muller's cone, right? So remember what did I tell you about the Muller's cone? That Muller's cone, which is the hypothetical inverted cone explained by Gas, actually has lots of xanthophyll pigment in it. So that xanthophyll pigment will undergo centrifugal migration or the lateral migration, and because of which that yellow spot will now be seen as a yellow ring. However, what was seen on OCT was that the initial cystic change which was seen in the inner retina in the stage 1A has now progressed to the posterior part, that means to the outer retina as well, and that forms your 1B. So at this point it is very important to remember that when Gas postulated his staging, there was no OCT available, right? The OCT classification has come later on. So this is your stage 1A and stage 1B. Now stage 1B is also called an occult macular hole because the hole seems to be hidden behind the retina. Still there is no opening in this impending hole in stage 1B. What about stage 2? In stage 2, as you would have guessed, now there will be an opening in that stage 1B of the Gas. Okay, so this opening can develop anywhere. Either it can be a central opening or it could be an eccentric opening like this. And on OCT, you can see this eccentric opening like this. Right? What is important over here to remember is that in stage 2, there is an opening, but a part of this roof is still attached to one point on the retina. So what you get is an operculum which is attached to one point of retina, and that is called stage 2 of Gas classification. Then what about stage 3? In stage 3, what will happen is that the operculum will totally get detached from the retina. However, the operculum is suspended in front of the retina with the hanging posterior hyaloid, right? So what I mean to say is that, have a look here. So this is the macular hole. Obviously, this is the full thickness macular hole. The operculum which was here has now moved forward because the vitreous or the posterior hyaloid has got detached from the macula. So you can see the operculum hanging with the posterior hyaloid, right? But in stage 4, you won't be able to see even that posterior hyaloid with the operculum. Right now, the question that arises is, which was present in the thumbnail, so what is the difference between this stage and this stage? So the initial stage is stage 3 and this is stage 4. So the difference here is just the matter of complete or incomplete posterior vitreous detachment. So in stage 3, although the posterior hyaloids get separated from the macula, it is still attached at one location, and that is optic disc. And that is the reason you can see the operculum still hanging somewhere near the macular area. But in stage 4, there is complete posterior vitreous detachment. That means the posterior hyaloid has got separated even from the optic disc, and that is why you do not see any operculum hanging even on the OCT. However, if you want to confirm whether it is stage 3 and stage 4, you have to see the presence of a V's ring on fundus examination, right? If there's a V's ring which is present, which is nothing but where the posterior vitreous gets separated from the optic disc, you will see a circular shadow suspended in the vitreous cavity, which indicates that there is a complete PVD present, right? So whenever you see a V-ring and a picture like this, that means you're dealing with stage 4 full thickness macular hole. However, if there's no V-ring, you see the operculum suspended like this in the first picture, okay, then you're probably dealing with a stage 3 macular hole. So this is how a complete macular hole is going to look like. You can see a circular defect in the retina, and surrounding you can see a cup of fluid because the fluid which went into the outer plexiform layer, and you can see certain dot like changes which are the RPE changes in the retina. So this is what was the gas classification. So in this video, I've already explained to you in brief what is the gas classification and the OCT classification. Another video on OCT in vitro disorders is present, which tells you in detail about the gas and the OCT classification with its correlation with the intravitreal traction society classification. So here, as you can see, the gas classification, we have the stage 1A in which you had a yellow spot. Stage 1B is yellow ring. Stage 2 is full thickness macular hole, okay, which is less than 400 microns, okay. So as I told you that the IVTS, according to IVTS, small is less than 250, but gas considered it to be less than 400. Stage 3 is full thickness macular hole more than 400, but here you can see no vitreous separation. What he means here is no complete vitreous separation. Stage 4 is full thickness macular hole more than 400 microns, but there is complete vitreous separation. That means vitreous has been separated even from the optic disc. So this was basically a biomicroscopic classification. Coming to the symptoms of macular hole, usually the patients will have a painless decreased central vision because fovea is in the center, so the patient has central vision problem. They will have a central scotoma, or sometimes they will have dysmorphic vision, which is called metamorphopsia. In many cases, patient may not even notice any vision loss unless the other eye is occluded. This is especially true if you're dealing with stage 1 macular holes, which are not present with much symptoms. Now, the reason for decrease in visual acuity is because there is a loss of the central retinal tissue. Moreover, there is this fluid which is present. There is surrounding retinal detachment and cystic changes. All these are going to lead to decrease in the vision of the patient. How do you diagnose the macular hole? Obviously, you have to do a fundus examination and OCT examination as an investigation. But there are two diagnostic tests which are actually available for diagnosing the macular hole, and these are the Watzke-Allen slit beam test and the laser aiming beam test. In the Watzke-Allen test, it's a very simple test done on a slit lamp using a fundus lens. A narrow vertical slit beam is actually projected onto the patient's fovea, and the patient is asked whether he sees a complete beam or he notices any break in the bar of light. If he notices any break, that is called a positive Watzke-Allen test, which means that there is a full thickness macular hole present in the retina. Based on the similar principles, we have the laser aiming beam test, which is actually done using a photocoagulator laser, which is about 50 micrometers width, and that beam is aimed at the presumed macular hole. The patient will not be able to detect the aiming beam within the lesion, but will be able to detect it if you project it in the surrounding intact tissue. So if this is a hole, if you put the beam in this area, the patient will not be able to detect whether there is a beam present or not. However, if you project it outside the zone of the macular hole, then the patient will be able to perceive it. So this test is much more sensitive compared to the Watzke-Allen test and more specific as well for full thickness macular hole. So that's all for today. Thank you and have a nice day.